were subjected to a very hard conditions by the fact that doctors were on strike for 100 days. They dubbed 100 days to give birth to this particular collective bargaining agreement. And therefore, as a union, we were hoping that the government will commit to implement the CBA. But 5 years down the line, the doctors have been faced with frustrations, and all attempts to have it implemented have not been possible, to the point that we declared dispute with the Ministry of Labour and with all the governments. We went to court, and court gave a judgment in October 2021 that there's a nil implementation of the CBA, and therefore the county governments and the national government was ordered to implement it within 60 days.
Right.
It's at this point, that 460 days later, that we were coming out to demand for it. And this came out after our special delegate conference, where we sat down to analyze the content of the CBA. We have seen frustrations of the public wanting to get the service provisions. So that's the time we gave a 30 days notice for intention to strike, which was then to commence today in January, that if we were not engaged and given framework to have its implementations, then we were to proceed on strike. But because we don't want to subject the public to that same pain, and because we want to actually have this thing implemented, and that they say, as much as you know that there's no new government, you only have new sheriffs in the government, they say they are different, and therefore they should be given 60 days to implement it. For that goodwill, for that olive branch, we said, fine, let's have the 60 days. But it's very clear, we will say, and what I've used that, is as a check. When you give out a check, a 6 days check, the check needs to mature within the 60th day. If the check then fails to mature, it means that the person who issued the check has insufficient funds, and that is a crime. And therefore, there is mechanisms that as a union we put in place to deal with that with both the county government and the national government, because this was a court order. And therefore, they can set them for contempt as we proceed for that industrial action. But we do not want to subject the public to that as at now.
Right.
Yes.
But so then who was involved? Of course, we've seen how the president has been hands-on.
Yes.
Was he roped into this whole process? Did you get a call from State House on this?
You see, one thing that is on this aspect is the Ministry of Health, the Council of Governors, and we have the Health Committee chaired by Mudomi Njuki, the governor of Tharaka Nithi, and we also have the Labour Committee that's chaired by Honorable Sakaja, and then you have the Minister of Health. So when these issues are down, it's within the government. So once you're having the negotiation and discussions with them, they must report this to the State House and must report that team. So at our point of agreement, they say we have committed this as the Council of Governors and also as the Minister of Health and as a state. And again, before we even had further agreements, you saw even the President giving acknowledgement of the issues that the CBAs need to be implemented. So by that, this moratorium time that we give to the government, it doesn't express weakness from the union. It expresses the willingness of the union to want the government to function and to want the public to get the services. So at the backdrop of them not implementing, it will now be the government that was on strike. Right. When workers withdraw the services.
Let's talk about the demands. I mean, for someone who's watching, for instance, a doctor who's trying to understand, what are some of the demands that were put in place and what has the government now promised to do?
When you look at the CBA, it's like a contract. It's a constitutional document because Article 41 of the Constitution gives the workers the right to bargain and the power to have this particular contract. So it's actually a supreme document. So once this was signed, there was an aspect of the salary, basic salary that was to be paid to the doctors. This has not been done for 5 years. That's the first part of it. The aspect of employing doctors to work in the facilities. There's a Musimi Task Force report that was done 10 years ago that gave a number of doctors that need to be employed in the facilities to make it work. That is 1,200. But you've seen that that was not done. And therefore, in all the facilities, you realize when the public goes to the hospital, on the public hospitals particularly, you have to wait for 10 to 15 hours to see a doctor because there's shortage.
Right.
And therefore, by implementing this CBA, it means that if you go to the hospital, 3-4 more doctors are employed, they instead of waiting for that 12 hours, you wait for 3 hours or 4 hours. We have seen those theater lists that people are waiting for up to 3-4 months. By implementing this document, then it means that the service will be provided. The other thing is the working environment. If you're a doctor in the hospital and then you want to diagnose a patient, you send them to the lab. But if there's no lab or there are no reagents or to that place or there are no drugs, then it curtails your process of doing the job. So that's why we're saying there needs to be provision for these particular things for the doctors to offer their services. Right. And that's part of the CBA. We have the aspect of the health cover.
Right.
The doctors are as human as everybody else, and they get ill and they get sick. So then they need to be covered. It's the situation whereby you as a doctor get sick and you go to the hospital, you don't have cover. You have to go back to your community and to get contributions to get the services. So, but they signed the collective bargaining agreement. So those are things that we're looking at, that they need to be having that implemented. So with all these plans, the county governments planned to have these issues implemented within the 60 days. Sometimes when people have told you that we acknowledge and we know we have not implemented this and there's a court order to the same effect, we're going to do it, then you give that time, it shows the goodwill on our side. It's an olive branch we gave to the Kenyans because we did not want this to start as their services are also interrupted. But then when that commitment fails, then as all human beings, as doctors, we are also humans who need to have the provisions for the structure will proceed. Right. One also of the biggest element of that is in existence also the issue of salaries. We have all over the country, the payment of salaries in the county is delaying 2-3 months. And one thing you must know is that the most honest of service providers in this country are the healthcare workers, because they only depend on their salaries. So at this time that the governments or county do not pay them 2-3 months, then they're subjected to frustrations and the mental conditions that make it difficult to get services to the public. So in all essence, this strike was not just for doctors. It is meant for actually the public to get better access to healthcare.
Let's talk about two issues here. Some of the things that the government, of course, has promised. One, the posting of the 1,000 medical interns by second week of January, and that they'll pay fees for all doctors on the postgraduate studies with immediate effect. Is it realistic, really?
It is realistic for the interns, because one thing that we know for this particular medical interns, ideally, it is the first time since independence of this country that we will have interns graduate and stay at home for a year or for 2 years before they're being posted. And yet, they play a backbone role in service provisions in these hospitals. So them being posted is a very important thing. And they say they'll post them by the first week. If they don't do that, it's a by them not being posted, it's a contravention of the CBA, because they were to be posted 30 days after graduating. That's one thing. Number two, we all know that the doctors that are going to school work at Kenyatta Hospital, they work at MTRH, they work at KUTRH, they work at these national referral hospitals. So therefore, they give service to the public. So, and the health is devolved function. It's a devolved function as human resource, while the training and policy component with the Ministry of Health. That means the budget is with that ministry. So it is possible for the ministry to pay all these funds or to commit to public institutions like University of Nairobi or more universities for these services to be offered. So what has been lacking is just the intention. So with this commitment, we believe they should do that, and there should not be a question of how or how it's being implemented.
Right. Let's talk about service delivery. Now, county healthcare, a lot of the times you find patients leaving the counties coming to Kenyatta National Hospital. In terms of devolution, the whole idea is to make sure that people get that service delivery from the counties. How is it going at this particular point?
And that is one of the essence of our notice, the dysfunctionality in the public health service delivery. As I said, there's a plan to have doctors employed every year, but within the last 5 years, in about over 80% of the counties, or almost the whole country, only about 5% of this number has been employed. So it means then all the level 5, level 4, level 3 hospitals that are in the counties are in those levels by name, but not by service delivery. We have an structure that has been put in place, but they don't have the doctors. You don't have the drugs. You don't have the equipment that are needed. So then all the public, when they go to the, and research by InfoTrack indicated 72% of the public will go to the public facilities, but they will not get those services. You won't get a doctor because a doctor has not been employed. So the only alternative is then to go to the national referral hospitals. That's why then the devolution of the healthcare is not working, and they have to make it work by investing more funds in it and by putting personnel to work with that. And also we saw it with the MES project. This is where equipments are put everywhere in the counties, but they're not working because they're not personnel. There was no harmonization of the structure to make it be beneficial to the public. Yes. In
terms of also, again, service delivery, why are Kenyans, going to India for treatment, and we have healthcare in this country?
And that's what's bringing us to this issue of the Cuban, because it's got line in line with that. And we see one of the biggest scandals for the government, the previous government, was probably this issue of the Cubans, because you look at it that employing one Cuba is equivalent to employing more specialists in the country. So the Kenyans are going to India or this other country because of the cost of healthcare.
Yes.
And the cost of healthcare, the indicators of it is investment in the public. and invest in the healthcare in the country, the government of Kenya has not invested adequately in the public healthcare. And this is indicated even by the budget that just forgone 2022-2023. We are only 4% of the total budget in healthcare. So you realize that in the public hospitals, they do not have the specialists that are needed. They do not have the equipment that are needed. They do not have all those things that are needed to offer these services. But we have the specialists who have graduated in the country. We have the doctors who have graduated, but they haven't been employed. So the only alternative to have a cheaper alternative to healthcare, you have to go to India, or you have to go to a private hospital in this country, which will then be expensive. So therefore, if there is more investment in healthcare and more funds to it, both in the national and the county government, by employing the human resource, by putting the drugs and putting all these other necessary things, then the cost of healthcare will go down, and there will be no need actually to go to India or to other countries.
But so what's the root cause of this problem? Because what I'm hearing from you is we do have personnel. We have specialists in this particular fields, right? So what is the root cause of the problem? Is it that the government are not investing in the people, they're not investing in the hospitals?
We have very good policies that actually will make healthcare work, but then the implementation aspect has become a problem. And if you look at it and we go back down to the counties, if somebody is elected as an MCA, or you're elected as, or you are a CEC, chief officer, you are a governor, deputy governor, or you are an MP, and you are this CS, all these people are consumers of private care, private healthcare. And you realize that the government actually pay a lot of premiums for the private insurance companies for them. So when they need this health service, they will not go to the public facilities that they actually own within the counties, including the governors. They'll go to the private hospitals or abroad for the services. And therefore, there's no interest to really make this healthcare work within the counties. So there should be a deliberate plan to actually make the consumers of healthcare to be those that are put to be in charge of it, by the CSS, the ministers, the PSS, and even the leaders in the counties. Because there's no way that you say you bake bread as a governor in the county, but then you don't eat this bread, you have to go to your neighbors to take the bread that they have there. The governors will all move to Nairobi Hospital to get services, while they manage the healthcare within the counties.
So is the devolution really working in this particular case, especially in healthcare?
There are two aspects to this issue. Number one, on the sides of the infrastructure, instead of building the hospitals, we will say that there has been more enhancement in building them, because this is what every Kenyan will see that has been done. But in terms of the service provision within those buildings that have been done, I will call them white elephant projects, that has been very low. And that is low because of the personnel that should offer the services and the equipment that are needed. But then, what the governors have been saying, which to a greater extent we support, is the budget proposal. If 15% of the entire budget goes to the counties and 40-50% goes to the healthcare, rather wage bills and the likes, therefore it is impossible for the counties to make any healthcare work unless there's an increased budget, or unless we create this health service commission that relieves the counties from the burden of paying workers.
Right. One of the other demands, of course, that I had seen was to establish a health service commission. What's the role of that?
As for my talk, one thing that health service commission will do will centralize the management of health. We have seen that the teacher service commission, based on it, there's a budget that ensures annual employment of teachers. For the police service commission, there's a budget for annual employment of the police service and and the prison workers. But then, I mean, the armed forces is a budget for that. But then when you come to healthcare, that the whole country considers to be essential, there's no budget for having healthcare workers employed. And therefore, if you have a centralized health service, the complaint that the counties have on the deficiency of budget, that has also been reported by the auditor, the control of budget, then now will be shifted off, because there'll be a central body that now is budgeted for, that ensures that every year 20,000 or number of healthcare workers are employed and they go to offer services in the counties. That county's role will now to be ensure that there's efficient service provision. The issues of promotions, the issues of this collective bargaining agreement, there'll be a particular one channel to have them implemented. But currently we are dealing with 48 governments in one government, meaning it is subject to a lot of emotions and decision of many teams to have it implemented. And most of the time, when anything is more direct and it's to be done by a group of people, it tends to really not be as effective as if there's a body that really analyzes and puts into place based on the policies that have been in existence.
Right. With all this, of course, going on, do you think Kenya can become a regional medical tourism destination, really?
It is possible to actually become a regional, and because if you look at the healthcare of this country compared to what we have in our neighboring countries, we are actually better off in terms of the services that are being offered. But one elemental value that will make that happen if we change our nature of the expenses in healthcare from recurrent expenditure to an investment aspect, where the country can see that if you have the healthy workforce, you have ability to provide healthcare to everyone, and therefore people will not worry about the healthcare, because currently many families with the middle class, you are just one disease away from actually being very poor, even if you have what type of insurance. So that means that if we have healthcare affordable to all, first of all, by actually investing in healthcare, because it can't be free as a government, then that will be easing the ability to make it a tourist destination, or rather touring. But the one thing that makes that difficult is if, as of now, we have over 5,000 doctors that are unemployed, we have over 1,000 specialists that are unemployed in the country, at the backdrop of severe shortages in the facilities. So that means our public healthcare is totally dysfunctional. So how will it be a medical tour if the public can't get that healthcare now? So we should be able to actually make it work for us first before we can actually look into that particular aspect of making it a destination.
Right, let's talk about now KMPDU as an organization. What is it doing to tackle this issue of cost of healthcare? We've talked about policies, we've talked about what the government wants to do, but from where you stand?
That's why I say the strike that you were to go to today was not for doctors, because these funds that we are demanding what we paid 5 years ago, it's not anything new of the CBA, but the critical component of this particular strike notice to ensure that doctors are employed in the public hospitals in the country. When there are doctors in the public hospitals, you will go to the hospital and the waiting time will be lower, and therefore you will get the services. Again, we're also demanding that there should be medicines and the quality equipment within the facilities. That means you get the lab services, you'll get the drugs, and there will be no going to a private facility or to chemist look for the drugs. So in that essence, the service delivery in the public will be enhanced. That alone reduces the cost of care. But when you go to the hospital and you don't find a doctor, you go to the hospital, there are no drugs, you go to the hospital, there are no labs, you'll have to go to the privates. And that in itself creates the demand within the private hospital facilities. But as you all know, the word private, when it comes into coexistence, is about profit. So that means every person has to look in how to get more money to get the services. So that alone is it's a critical component that must be looked into. And then putting every Kenyan to have insurance, be it private or public or in the Shahev, that actually ensures that wherever you are accredited, you can actually get this care. That will ensure that there is public service delivery or enhanced public service delivery to the Kenyans. And that's what we are advocating for as KMPDU, because there's no healthy doctor without a healthy patient. If you are seeing a patient and you're not able to treat them, that they go home, then you feel frustrated. When you lose a patient as a doctor, you lose part of yourself. And that's why it is not important to be in the hospital just to watch patients suffering, when you know that if there are more doctors, if there are more equipments, the more drugs, then all this can all be sorted out.
Right. Let's just finally, to wrap up, if there's any doctor who's watching that now, when you talk to a doctor or even an intern right now, what would you tell them?
I will tell them that I know it's very painful that we have suspended the strike that was to begin today and the intention to strike. But it's very important to also give goodwill to these particular new sheriffs of the government. But then that does not make us stop being vigilant on the issues that we demand. That our aim is to offer the best care we can to the patients. And we as a union and as a team, we are going to work together towards that. So let's all prepare and mobilize and be sure that these issues that we are handling, from the facility level to the highest level of the facility of service delivery, we undertake, to the point that if the government fails, it will not be upon us. It will be then the government that fails the Kenyans. But let's uphold and do the best we can within this period to ensure that we put the government into account for this. The second thing is that this particular agreement that we had is a court document that we have to deposit as a consent. Therefore, if there's a failure to its administrations, we will cite the government and the county government for contempt of court, at the same time as we sanction any other action that will ensure that Kenyans get the best health care.
Right.